Imagine arriving at an emergency room with crushing chest pain, only to be left in a crowded hallway for 6 hours while the few remaining nurses scramble between dozens of critical patients. This is not a hypothetical scenario born of a sudden natural disaster, but the engineered reality of hundreds of hospitals across the United States. Behind the triage desk, the decisions dictating your wait time, the number of doctors on shift, and the quality of your care are increasingly not made by medical professionals. Instead, they are calculated in distant corporate boardrooms, driven by a quiet, relentless takeover of emergency medicine by private equity. For decades, emergency rooms were staffed by independent local groups of physicians who contracted directly with hospitals to provide round-the-clock care. That model was systematically dismantled when massive financial firms recognized a captive market with inelastic demand. When you have a medical emergency, you cannot shop around for the most cost-effective facility. Private equity giants saw this vulnerability as an untapped revenue stream. They began aggressively acquiring physician staffing companies, rolling up local practices into national conglomerates. Two of the most dominant players to emerge from this consolidation were Envision Healthcare, backed by KKR, and TeamHealth, acquired by Blackstone. The mechanics of these acquisitions relied heavily on a tool known as a leveraged buyout. In this financial maneuver, a private equity firm purchases a company using a massive amount of borrowed money and then transfers that debt onto the balance sheet of the acquired company itself. When KKR bought Envision and Blackstone took TeamHealth private, the staffing companies were suddenly saddled with billions of dollars in high-interest debt. The private equity sponsors contributed only a fraction of their own capital, insulating themselves from catastrophic risk while demanding aggressive returns to service the newly acquired loans. To keep up with those crushing debt payments, the newly acquired staffing firms had to drastically increase their cash flow. The primary metric of success shifted from patient outcomes to EBITDA, an acronym for earnings before interest, taxes, depreciation, and amortization. Maximizing EBITDA in a hospital setting leaves very few levers to pull. You cannot easily negotiate cheaper bandages or generic drugs in an emergency department. The only significant, immediate way to extract the required capital is by shrinking the largest line item on the budget, which is human labor. The restructuring echoed through every ward, fundamentally altering the reality for doctors and nurses on the ground. Staffing matrices were aggressively trimmed to the absolute legal minimums, and sometimes below them. Physicians who previously managed 2 or 3 critical patients an hour were suddenly pressured to see 4 or 5. Overlapping shifts were eliminated, leaving skeleton crews to manage the chaotic, unpredictable surges of a busy trauma center. Nurses found themselves stretched across multiple bays, unable to monitor vital signs with the necessary vigilance, creating an environment where critical changes in patient conditions could easily go unnoticed. For the patients trapped in these waiting rooms, the consequences of these stripped-down rosters were immediate and dangerous. A delayed diagnosis in an emergency room is not merely an inconvenience. It is a matter of life and limb. Reports began surfacing of patients suffering catastrophic strokes in waiting chairs because triage nurses were too overwhelmed to perform timely neurological assessments. Others with internal bleeding were left unmonitored for hours until their conditions became irreversible. The relentless drive for corporate efficiency had stripped away the vital buffer of time and attention that emergency medicine requires to function safely. To bypass laws designed to prevent this exact scenario, these financial firms exploited regulatory gray areas. Many states have strict doctrines prohibiting the corporate practice of medicine, meant to ensure that only licensed physicians, not corporate executives, make clinical decisions. Private equity firms circumvented these protections by setting up captive professional corporations. On paper, a physician owned the local medical group, but through complex management service agreements, the private equity parent company controlled the hiring, the firing, the scheduling, and the billing. The doctors were left with the liability, while the investors held the power. This shadow control allowed the staffing giants to implement another highly lucrative, deeply controversial revenue strategy. Because emergency patients cannot choose their doctors, Envision and TeamHealth frequently kept their physicians out of the insurance networks that the host hospitals accepted. When patients arrived at an in-network hospital, they were unknowingly treated by out-of-network private equity doctors. Weeks later, those patients would receive devastating surprise bills for thousands of dollars. It was a deliberate, weaponized billing strategy designed to force insurance companies to the negotiating table and extract higher reimbursement rates to feed the corporate debt machine. For years, regulators failed to intervene, allowing this predatory billing practice to become a cornerstone of the private equity emergency room playbook. The profits generated from surprise billing were not reinvested into hiring more nurses or buying better equipment. Instead, they were siphoned upward to satisfy the leveraged buyout loans and to pay out lucrative dividends to the private equity sponsors. The financialization of emergency care had successfully turned the vulnerability of sick and injured citizens into a reliable, high-yield asset class, while state and federal health agencies watched from the sidelines. Inside the hospitals, the pressure to maintain this revenue stream created an agonizing moral dilemma for the medical staff. Whistleblower testimonies and lawsuits revealed that doctors were routinely pressured to aggressively upcode their charts, meaning they were instructed to bill for more complex and expensive procedures than were medically necessary. Physicians who pushed back against these corporate mandates or who complained about the dangerous understaffing frequently found their contracts terminated. The independent medical judgment that is supposed to be the bedrock of patient safety was being systematically overridden by the threat of unemployment. The human toll of this environment extended far beyond the financial ruin of surprise medical bills. When doctors are forced to prioritize speed and billing metrics over thorough clinical evaluation, mistakes inevitably multiply. A rushed physician might order an unnecessary expensive CT scan to quickly triage a patient, exposing them to radiation, or conversely, might discharge a patient prematurely to clear a bed, leading to a fatal complication at home. The sanctuary of the emergency department had been transformed into an assembly line where patient volume and rapid turnover were the only metrics that mattered. The lucrative house of cards began to wobble when public outrage over surprise medical bills finally forced legislative action. The passage of the No Surprises Act fundamentally disrupted the core revenue model that KKR and Blackstone had relied upon to service their massive debt loads. Suddenly, the staffing companies could no longer weaponize out-of-network billing to extract inflated payments. With that revenue stream severed, the crushing reality of the leveraged buyouts came due, and the private equity sponsors had to find new ways to squeeze capital from an already depleted healthcare system. The legislative intervention, while crucial for protecting patients from financial ruin, exposed the fragility of the private equity healthcare model. Because the entire structure was built on aggressive debt and maximum extraction, any regulatory correction threatened to collapse the staffing firms. Instead of accepting lower profit margins or injecting their own capital to stabilize the companies, the corporate owners doubled down on their cost-cutting playbook. The systemic vulnerability of allowing essential emergency services to be governed by speculative finance was laid bare for the entire medical community to witness. Envision Healthcare's response to this financial pressure was a masterclass in ruthless corporate preservation. To further slash labor costs, the company aggressively accelerated the replacement of board-certified emergency physicians with mid-level practitioners, such as physician assistants and nurse practitioners. While these professionals are vital to the healthcare ecosystem, they require appropriate physician supervision when handling complex, undifferentiated emergency cases. The private equity model, however, stretched this supervision to the breaking point, requiring a single doctor to sign off on the charts of multiple mid-level providers simultaneously, often without ever laying eyes on the patients. The daily reality of this substitution strategy left seasoned emergency room doctors experiencing profound moral injury. They were legally and ethically responsible for dozens of patients they could not adequately evaluate. A physician might be managing a cardiac arrest in Trauma Bay 1, while simultaneously being expected to supervise the care of a complex sepsis patient being treated by a mid-level provider in another wing. The cognitive load was unsustainable, leading to massive burnout and driving many experienced emergency medicine specialists to leave the profession entirely, further exacerbating the staffing crisis. For the unsuspecting public, this meant that walking into an emergency room no longer guaranteed access to an emergency medicine physician. Patients presenting with subtle, life-threatening symptoms, like an atypical presentation of a pulmonary embolism or a pediatric neurological emergency, were increasingly evaluated by practitioners with significantly less specialized training. Tragic, preventable outcomes became the silent collateral damage of this cost-saving measure. Families lost loved ones because critical diagnostic windows were missed in chaotic, under-resourced departments where the most highly trained experts were spread too thin to intervene. Blackstone's management of TeamHealth followed a parallel trajectory of financial engineering and extraction. Even as the staffing company faced mounting legal challenges over its billing practices and faced the same regulatory headwinds, the private equity sponsor continued to prioritize its own returns. Financial records indicate that these firms utilized complex debt restructuring and dividend recapitalizations, a process where a company takes on new debt specifically to pay a special dividend to its private equity owners. The staffing firms were being hollowed out from the inside, their assets stripped to enrich investors while the hospital floors starved for resources. The aggressive consolidation driven by these acquisitions left many communities trapped in a dangerous monopoly. In certain regions, a single private equity-backed firm controlled the emergency staffing for nearly every hospital within a 50-mile radius. If a hospital administration grew dissatisfied with the declining quality of care or the aggressive billing tactics, they found it nearly impossible to switch providers. The local independent medical groups had been bought out or driven into bankruptcy years ago. The free market illusion had vanished, replaced by a corporate chokehold on regional emergency care. Healthcare workers trapped within this monopoly found themselves silenced by strict non-disclosure agreements and non-compete clauses. If a doctor attempted to speak out about the dangerous patient-to-staff ratios or the lack of life-saving equipment, they could be fired and legally barred from practicing medicine at any other hospital in their community. These punitive contracts effectively gagged the very professionals who were best positioned to sound the alarm, ensuring that the deterioration of patient safety remained hidden behind the closed doors of the emergency department. The ultimate cost of this mandated silence was borne by the most vulnerable patients. When an understaffed ER is overwhelmed, it is the elderly patient with quiet sepsis, or the non-English-speaking patient with atypical pain who falls through the cracks. The tragedy of the private equity model is not just the spectacular headline-grabbing failures, but the daily, invisible accumulation of delayed care, prolonged suffering, and diminished outcomes. It is the realization that in your moment of greatest physical crisis, the system designed to save you has been optimized to commodify you. When the debt burden finally became mathematically unmanageable, the endgame of the private equity playbook was deployed. In 2023, Envision Healthcare filed for Chapter 11 bankruptcy, buckling under the weight of billions of dollars in debt that had been loaded onto it during the KKR buyout. But this was not a traditional business failure. It was a calculated restructuring. The bankruptcy process allowed the corporate entity to shed its crushing liabilities, renegotiate its contracts, and wipe out the equity of lower-tier investors, all while the primary private equity sponsors had already extracted their management fees years prior. The architecture of private equity ensures that the architects of the collapse rarely suffer the consequences. Through intricate corporate shielding, the parent firms insulate their core funds from the bankruptcies of their portfolio companies. The billions wiped out in the Envision bankruptcy impacted creditors and the broader financial ecosystem, but the private equity executives who engineered the initial leveraged buyout walked away with their personal fortunes intact. The risk was entirely socialized, borne by the healthcare system, while the profits had been thoroughly and aggressively privatized. The wreckage left in the wake of these corporate restructurings is devastating for local healthcare infrastructure. Hospitals that relied on these massive staffing firms are often left scrambling to maintain basic emergency services. In rural and underserved areas where profit margins are already razor-thin, the collapse of a private equity staffing contract can lead directly to the closure of the emergency room entirely. Whole communities are suddenly left without access to immediate, life-saving care, forced to drive hours to the nearest facility because a distant financial gamble failed to pay off. The persistent failure to protect emergency medicine from predatory financial extraction highlights a massive blind spot in American healthcare policy. While lawmakers have attempted to address the symptoms, like surprise billing, they have largely failed to confront the underlying disease. The loopholes that allow corporate entities to bypass the corporate practice of medicine laws remain wide open. Until regulatory bodies strictly limit the use of leveraged buyouts in essential healthcare services and enforce transparent staffing ratios, the financialization of the emergency room will continue unabated. The crisis of understaffing in our emergency rooms is not an accident of nature or an unavoidable consequence of modern medicine. It is the deliberate output of a financial model that views human vulnerability as an opportunity for arbitrage. When private equity firms like KKR and Blackstone acquired the engines of emergency care, they fundamentally altered the calculus of survival. The doctors and nurses fighting to save lives are doing so in a system designed to extract wealth, leaving patients to pay the ultimate price. True accountability will only arrive when we demand that the sanctity of the emergency room is protected from the insatiable demands of the balance sheet.